All right, so to do this problem, it's how long before they're going to get 1.2 millisieverts at this dose rate. So I'll put my 1.2 millisieverts here, and then I'll put this in as a conversion, 0.6 millisieverts per 1 hour. Is the answer an hour or minutes?
For the day, and the limit is for the day. How long does in the area? Yeah.
Okay, so all I'd have to do is take 1.2 times 6 divided by 0.6. I'm sorry, 1.2 times 1 divided by 0.6, and the answer is 2 hours.
Okay. So if the limit is for the day, do I have to convert anything else?
No, you just use that. It's like, this is the maximum amount he can have in 1 day, and he's already gotten this amount. So that means he can still get this much more before he gets this amount. And then all I do is say, okay, he can get 1.2. This is the dose rate. At that dose rate, it's going to take 2 hours to get 1.2 millisieverts.
Okay.
All right. Any other questions?
All
right. So this hour, we're going to do endocrine. And then the second hour, we're going to do cardiology. So we're going to start with endocrine. We're just going to talk about these studies. We're not going to talk about this one. So the basic ones. Do you do I-123 uptake and scans at your work?
Yes.
Yes. Okay. All right. Do you do any whole body scans?
Mostly I-131 for the post-therapy.
For the uptake?
Uptake, I don't see a lot. Usually it's the post-therapy.
Oh, the post-therapy. Okay. So post-therapy, doing a scan post-therapy.
Yes.
Okay. All right. What about parathyroids? Do you do those?
Parathyroid, rarely.
Rarely. Okay. All right. So we're going to cover all three of those today. So the endocrine system itself, the pituitary gland, the thyroid gland, and the parathyroid glands, those are the ones that we're going to be talking about. Pituitary gland is located right here in the brain. Right behind it is the hypothalamus. And these two actually work closely together in making thyroid hormone. Now, anatomically, a couple things I want to point out. The isthmus, this is the band of tissue that holds the right and left lobes together. And the pyramidal lobe, this is some tissue that points upward. Sometimes you see it and sometimes you don't. You usually only see it with Graves' disease. Okay, so I want you to look at this image. This one's anterior. Both of these say RAO. Which one do you think is the true RAO?
The C is the RAO.
Yes, very good. Because if I outline, you can tell that this one is bigger. And so that means it's closer to the camera. This one is bigger. So that means that is the LAO. Excellent job. All right, the parathyroids are located posteriorly to the thyroid. There's two superior and two inferior. Again, this is that pyramidal lobe. Sometimes you see it on imaging. You usually only see it when the patient has a lot of uptake, so like with Graves' disease. All right, so thyroid hormone synthesis, the way that thyroid hormone is made. This is outside of the cell. This is in the cell. This is the cell membrane that it has to cross over. So the iodide crosses over the cell membrane. It does that via active transport. And when it does that, it gets on what I call the thyroglobulin bus. The job of thyroglobulin is to drive a bus around the thyroid, and the thyroglobulin is not allowed to leave the thyroid. It has to stay there. And what thyroglobulin does is on its bus, it has a molecule called tyrosine. When the iodine crosses over, the iodine gets on this bus with the tyrosine, and they form two separate things. If you have one iodide and one tyrosine, it's monoiodotyrosine. And if it's two iodines and a tyrosine, it's diiodotyrosine. If you take one mono and one di, that's 1 plus 2, that gives you T3. Two diiodotyrosines gives you T4. 2 plus 2 is 4. All of this is happening on the thyroglobulin molecule. Once the T3 and T4 are formed, then the bus continues driving until it gets to its last stop, which is the cell membrane. It drops the T3 and the T4 off, and then it goes back on its route, and it's going to continue to do the same thing. Now, once T3 and T4 leave, which are the thyroid hormones, the T4 can be bound to thyroxine binding globulin. Thyroxine means T4. So T4 can be bound, which means it's not available to use. Once the T4 becomes unbound, or what we call free T4, then it can be turned into T3, and that's what our bodies are going to use to regulate metabolism and do all kinds of different things. So T3 and T4 are responsible for all of these different things. So that's why it's important for us to have that in the body, and how our body regulates the amount. So what I just went over is how it makes the T3 and T4. This is how it regulates the right amount. So here's what we talked about. The iodide comes in, forms the mono and diiodotyrosines, form the T3, and then it leaves. When we have high T3 and T4, it causes the anterior pituitary and the hypothalamus to shut down. So then we have low thyroid stimulating hormone. When we have low thyroid stimulating hormone, it shuts this down. And so then our T3 and T4 go down. So what's happening is you have one goes up, then the other goes up. This one comes down, then this one comes down. So it just keeps regulating itself. It's kind of like a dog chasing its tail. It just keeps going until you reach some kind of homeostasis. So when we get labs, there's 4 different labs that we can get. The TSH lab. TSH is what we diagnose hyperthyroidism. If they have low TSH, that means they have hyperthyroidism. We're also going to get a corresponding T3 and T4 level, because that's going to be high if they have hyperthyroidism. Now, thyroxine binding globulin, this is what differentiates T4 from free T4. So sometimes when you get the labs, you see, oh, this is their T4 level and this is their free T4 level. If they have a lot of thyroxine binding globulin, they're not going to have a lot of free T4. And so that prevents them from using that T4, converting it into T3 into a metabolically form. Thyroglobulin. This, remember, is the bus that's in the thyroid. This becomes very important when somebody is diagnosed with thyroid cancer, because when you're diagnosed with thyroid cancer, they take the thyroid out. And if they take the thyroid out, you should have no thyroglobulin in your body, because thyroglobulin is only found in the thyroid. So when patients get follow-up for thyroid cancer, we're going to take a thyroglobulin level. And if their level starts going up, it tells us their thyroid cancer is back. All right. So TSH, this is what we use to diagnose hyper or hypo. And it's going to be the opposite. High TSH means hypo. Low TSH means hyper. T4 is also known as thyroxine or tetraiodothyronine. I know we have 3 names for everything. But T4 loses an iodine, becomes MIT, and becomes T3. Oh, taken synthetically, it's called Synthroid. T3, also known as triiodothyronine. And again, it's made from T4 minus 1 MIT. Thyroxine binding globulin, this is not thyroglobulin. So a lot of people get those mixed up because they sound the same, but they're different. Thyroxine binding globulin binds the T4 until it's needed. It doesn't bind the T3. Thyroglobulin is what stays in the thyroid that we use as a tumor marker to see if the patient's cancer has come back. So it should be less than 10 milligrams per milliliter. If it's above that, then it's suspicion for the cancer coming back. All right, so let's talk about hyperthyroidism. There's a lot of different types of hyperthyroidism. So there's Graves' disease, multinodular goiter, and adenoma, and thyroiditis. This one's Graves' disease. We call it a diffuse. Diffuse means that the radioactivity is throughout the entire thing. So sometimes when we refer to viability studies, we're looking for diffuse activity throughout the entire myocardium. So diffuse means throughout. Toxic, this means that they're overproducing thyroid hormone. And goiter just means enlarged thyroid. So that's what those 3 words mean. This is where we'll see that prominent pyramidal lobe. It'll be uniform uptake. You really can't tell the difference between Graves' disease and normal on a scan unless you're looking at the size and the count rate. Those are the 2 things that will tell you that it's Graves' disease. Cancer in these patients is very rare. Exophthalmos, this refers to the eyes bulging. So patients that come in that are hyperthyroid, a lot of times those eyes are bulging. TSH is going to be very low. T3 and T4 are going to be high. Uptake in this case is going to be 40 to 70%. So really, really high uptake. All right. If we know the patient has Graves' disease by looking at their labs, TSH, T3, T4, this question is for you. Why do we do an uptake?
To see the function of the thyroid.
Yeah, to find out how hyper they are. Because if I have two patients, I have patient A and I have patient B, and patient A has a 40% uptake and patient B has a 70% uptake, which one gets the higher dose of I-131?
Patient B.
Nope, it's patient A. Because our whole goal, okay, so it's opposite what we think. Our whole goal is to make them hypo. And we want to make them hypo because we can give them a T4 pill for the rest of their life and they're going to be just fine. We can't make them normal. All right. So what we're going to do is we're going to give them I-131. If I give both of these patients 25 millicuries of I-131, this patient's going to get a whole lot more than this patient will, because this patient's going to take up 70% of it. So I don't have to give this one as much as I have to give this one. All right, this is what Graves' disease looks like. It's an enlarged thyroid, a lot of counts. All right, now this one. Solitary means one. Autonomous means it's not paying attention to the TSH. This thing right here is just decided that it's going to create as much thyroid hormone, as much T3 and T4 as it wants to. So that's what autonomous does. And nodule, it's just a mass. So my question for you is, if this is that autonomously functioning nodule, how come I don't see this lobe of the thyroid?
Because it's shut down the other one. The other one is taking a lot of the uptake already.
It's shut down because this is producing a lot of T3 and T4. So it tells the anterior pituitary, shut down the TSH. And if there's no TSH, this part of the thyroid, which is normal, is not going to take up the iodine because there's no TSH telling it to. So we can say that this nodule is suppressing this lobe. Sometimes a hot nodule will suppress it, and sometimes it won't. So in B, it's suppressing this side. In A, you can still see the thyroid. So B, we say that it's being suppressed because the T3 and T4 are so high that the TSH is really low. All right, multinodular goiter. Multinodular just means there's more than one nodule. It's not a solitary nodule. Goiter is enlarged thyroid. These are when you get images that just look yucky, okay? We really don't have goiters anymore because we put iodine in our salt now. Goiters were caused by lack of iodine. And so once we started putting iodine in salt, people stopped getting goiters. And the reason is because your thyroid is like wanting to make thyroid hormone. So it's trying to work really hard to find iodine. And so anytime you have a gland or a muscle that's working hard, it's going to get big. And so that's why it turns into this toxic multinodular goiter. All right, so this one's going to be normal. This one's Graves' disease because it's enlarged compared to the normal one, and there's a lot more counts. Toxic multinodular goiter because you have multiple nodules, and toxic adenoma, one solitary nodule. Now, cold areas, these cold ones, these are the ones that correspond with cancer, which is opposite from what we're used to. We're used to hot meaning cancer, but with thyroid, cold means cancer. Okay, let's skip that. All right, thyroiditis. This is the weird one, okay? This is the one that took me a long time to really understand. When your thyroid gets sick, and that's what thyroiditis is, your thyroid is sick. When it gets sick, all of the thyroid hormone that your body has made dumps. It just floods the system. It's like, I'm out of here. I don't want to be around a sick thyroid. So all of a sudden you have all of this T3 and T4 in your body. Flood of T3, T4. So your body thinks hyperthyroidism, high T3 and T4. So then your pituitary, in response to this high T3 and T4, it shuts down, low TSH. So if I have low TSH, what happens? I'm not going to take up any thyroid hormone. Now, when the patient comes to us, we don't know that. We don't know they have thyroiditis. We think they have hyperthyroidism because they have a really low TSH, and that's what low TSH means. But what happens is we're thinking they're going to be hyperthyroid. Their uptake is less than 1%, and this is what their image looks like. You can barely even see the thyroid. And that's because they don't have hyperthyroidism. They have a sick thyroid that dumped all its hormone, causes the TSH to tank, and the thyroid's doing what it's supposed to be doing. It's resting. So since the thyroid needs to rest, because whenever something is sick, we need to rest. So the thyroid needs to rest when it has thyroiditis. So what are we going to do? We're going to give them thyroid hormones, because if we give them T4, it causes the TSH to go down. And if the TSH is low, then the thyroid doesn't have to work and it can heal. It can rest. All right, your turn. This one's normal. So what's this one?
This one, Graves' disease.
Yes. What's this one?
This one is a toxic, multi-toxic.
Multinodular goiter. Yeah. All right. What's this one?
The toxic adenoma.
Toxic adenoma. Yep. And then what's this one?
This thyroiditis.
Yes. Excellent job. All right. So all the things that we can do a thyroid scan where we're taking a picture of the thyroid. We can do a thyroid uptake just to see how much function there is. So we'll do that with the thyroid probe. Whole body scan looking at thyroid metastatic disease throughout the whole body. And then we can do thyroid therapy. 2 therapies we can do is hyperthyroidism and thyroid cancer. Now, different radiopharmaceuticals can be used for different purposes. And so this is what we need to know. I-131, we can use that for the uptake of the thyroid. And we can use it for whole body imaging, but we can't use it to take a picture of the thyroid. We can use it to take a picture of the whole body, but we're not going to get a picture of thyroid. And that's because it's a long half-life. It's a beta negative and a high energy gamma emitter. So that gamma does allow us to get images, but because if they have not been diagnosed with thyroid cancer, we have to give them less than about 20 microcuries. And that low of activity, we're not going to get enough counts to get a good image. Get enough counts for an uptake, but not an image. I-123, this is the one we like. So we can do an uptake, we can scan the thyroid, and we can do whole body imaging. So this one we can do all 3. And that technetium, scan only. Because what happens with technetium, it does the same thing that I-123 does when it goes to the thyroid, crosses the cell membrane, it gets on the thyroglobulin bus, but it takes one look at that tyrosine and it says, no, I'm not connecting with you. And so it gets stuck on the bus because the thyroglobulin bus is like, I'm only dropping off T3 and T4 and you didn't turn into T3 and T4. So we say that technetium gets trapped, but not organified. Organification is the making of the thyroid hormone. So with tech, we can't do an uptake. We can't look at the process of organification. We can only look at the scan. All right, I-131, this is given orally. Again, uptake, whole body, and therapy. And these are the characteristics of I-131. Just make sure you know all those. Uptake, if you're doing an uptake, very small dose, 4 to 30 microcuries. And usually if you're going to use I-131 for the uptake, you'll pair it with Tech 99M for the scan. So you can do an uptake with this one and a scan with this one. I-123, you can do the uptake and scan using the same dose. You can do anywhere between, let's make that 3 and 6 hours or 16 to 24 hours post. These are the imaging characteristics, or the characteristics of the radionuclide. Dose 200 to 400 microcuries, and you should be able to get a good count rate. This is actually better than low dose I-131. Straight tech, again, trapped but not organified. You inject it, you wait 15 or 30 minutes to take image. Super easy to do. It's also not affected by the iodine in your body. So if the patient has had a recent contrast study and they have a lot of iodine in their body, you can, and you give them I-123, you're not going to see anything. But if you give them technetium, you will.
And will be no prep of this one?
No prep. Yeah, no prep. All right, so why do we do the scan? All right, so we do the uptake to figure out the function. We do the scan to see what type of hyperthyroidism they have, because a toxic multinodular goiter is going to look different than a toxic adenoma. It's going to look different than thyroiditis. It's going to look different than Graves' disease. And based on the type of hyperthyroidism, that also determines the sensitivity it has to the radiation you're giving it. Okay, so the uptake is to confirm hyper or hypo, because sometimes they could be thyroiditis. And we use it to calculate the dose, because the more hyper they are, the lower dose they get. We also, after therapy, assess residual amount, because when we take, when they have their thyroid removed, they always leave a little bit of the thyroid there. We call that the thyroid remnant. And that thyroid remnant is going to take up that therapeutic dose. So we can assess to make sure that that thyroid remnant took up that dose. Okay. So how do we do this? We're going to get a I-123 pill. And the I-123 pill, we're going to take that, we're going to put it into our phantom, and we're going to count the pill. Then we're going to count the background. So we're going to count the phantom without the pill. Then we're going to give the pill to the patient and have them come back 6 to 24 hours later. When the patient comes back, we're going to count the patient's thyroid, and then we're going to count their thigh. Their thigh is going to be their background count. And so we use the thigh because it's about the same size as the neck, and it's away from the thyroid, so it'll tell us what's circulating in the body and not in the thyroid itself. Then when we do the actual calculation, we're going to take the patient's counts divided by the total counts what we gave to the patient. So whenever we do a percentage calculation, and it could be a percentage of anything, it could be the percentage of function in the right upper lobe of the lung, it could be the percentage of function in the right kidney, it could be the percentage of free tech in our dose. Whenever you're doing the percentage of something, that goes in the numerator, percentage of thyroid function. The denominator will always be the total. So these are your normal values. At 4 to 6 hours, about 6 to 18%, 24 hours, 10 to 35%. Why would you do a 4 to 6 hour uptake?
To make sure the pill is going down.
Okay, all right. The patient might be really hyperthyroid, which is causing that iodine to turn over very rapidly in their thyroid. And so if we suspect that they're super duper hyper, we want to catch it early, because by the time they come back at 24 hours, they may have already turned that iodine over and we're going to miss it. So we might take an early one for that reason. All right, let's go through a calculation. So we have our 24-hour data. These are our capsule counts before the patient. This is our background. This is our thyroid. And this is our thigh counts. How do you set this up?
The pill minus the back 969140 minus 787, and then 167136 minus 374.
Okay, one more thing you have to do.
Oh, times 100.
Okay, one more thing you have to do. So this is the patient, right? This is what you gave the patient. You counted this at time 0 and you counted this 24 hours later. We have to decay. We have to decay this. Okay. So we have to decay at 24 hours. What's the half-life of I-123?
13 hours.
Yes. So I'm going to figure out my 24-hour decay factor.
would be 0.27, 0.28.
8. Okay, so I need to multiply my denominator by 0.28. Okay, so my numerator is going to be 167, 136 minus 374. So 166,762. And my denominator,
2713718.
okay. A little different because of rounding, that's fine.
Uh, 61.5.
Yeah, 61%. Excellent job. I think you've got that. So these next few slides just kind of walk you through that. I gave you a 6-hour one as well. And so answer here is 9%. So when you have time, go ahead and go through the calculation and just make sure you get the same answer. All right, there is a second protocol, and the second protocol involves, instead of counting the pill and then giving the pill to the patient, we're going to get 2 pills. We're going to have a separate pill as the standard. And what you do is you take one pill and you give it to the patient, and the other pill you put in the hot lab. They're identical pills. And then when the patient comes back, you count the pill and then you count the patient. Everything is the same, except you don't have to decay, because that pill is decaying alongside the patient. So when you sit for your board exam, if you get a question like this, ask yourself, is it the same pill? Because if it's the same pill, I have to decay it. If it's 2 pills, then I don't have to decay it. So this answer is 50%. And notice the equation's the same, patient in the numerator, standard in the denominator, but I did not decay it. Okay. Thyroid scanning. So again, we're going to do the uptake to see if they're hyper or hypo, and we're going to do the scan to see what type of hyperthyroidism they have. All right, let's talk about the pinhole collimator. With the pinhole collimator, that is going to be actually the highest resolution collimator we have. So this is the aperture. The thyroid is imaged and it's going to be inverted, so it's going to flip. And it's also the only collimator that when we bring it closer to the patient, it's going to increase the size. So that's why it's always important when we image the thyroid, we maintain the same distance. And it used to be, it was the distance that caused, because when we used to image, the counts we collected went right onto the film. And so it was the distance that made the thyroid the same size on the film. Not so much that anymore, but we can't tell if the patient's thyroid is enlarged if we have the distance inconsistent. All right, what else? 3 images, anterior, LAO, and RAO. These are 45 degrees, and it's better to move the camera instead of having the patient turn their head. It's not a true LAO if the patient turns their head. You actually need to move the camera around. Okay, normally the right lobe will be a little bit bigger than the left. That's normal. The isthmus is usually not visualized. You may or may not see the pyramidal lobe. A sublingual thyroid, this is what it looks like. That's a sublingual thyroid. What that means is during embryological development, the thyroid, as it's migrating, it gets stuck at the base of the tongue. And it doesn't hurt anything. It just gets stuck there. And so you have this big hot spot in the back of the mouth. Okay. Cold nodules. If you see cold nodules, this is probably too high. I don't think 20 to 30% is cancer. It's probably less than that. But those are the patients that are going to go on and get a biopsy. Hot nodules, that's fine. Okay, so hot nodules, they're called toxic. Why are they called toxic?
They're overproducing.
Very good, overproducing. So they're hyperfunctioning. You might not see the rest of the thyroid because of low TSH. Yeah, okay. And then subacute thyroiditis, we talked about that. All right, now let's switch gears and go to thyroid cancer. So our jobs with the thyroid, we're going to detect the cancer, we're going to see if it spreads, and we're going to treat it. So it's like a one-stop shop. This was actually our one-stop shop. This was actually our very first theranostics. Now we have 6 types of thyroid cancer. So differentiated means that the cells have grown and they have the characteristics of that tissue. So they're differentiated into that type of tissue. So differentiated thyroid cancer means that they act like thyroid cells and they're going to take up iodine. Undifferentiated thyroid cancer means that they don't take up iodine. And sometimes through the course of the disease, they start differentiated and they're going to take up the iodine. And as the disease progresses, they undifferentiate or de-differentiate. And then there's new medications now that can cause the thyroid to redifferentiate. So if it becomes de-differentiated, we can redifferentiate it, and then they're eligible for I-131 therapy again. But most of the thyroid cancer, 90%, is differentiated, which is good. That's what makes thyroid cancer a good one. It does trap and organify iodine. The types, papillary is the most common, follicular is the second, and it has a really good survival rate. Other types, medullary, undifferentiated, lymphoma, and then other cancers that have spread to the thyroid. These cancers do not trap and organify iodine. So if thyroid cancer doesn't trap and organify iodine, how do we image it? How do we usually image cancer? PET. Yeah, PET. We're going to image them with F18 FDG. Yep. So if their cancer no longer traps and organifies that iodine, we're going to do PET. So we're following these patients, right? They have thyroid cancer. We're following the patient. All of a sudden, their thyroid globulin level goes up. We do a whole body scan. We can't see it. There's no uptake. We suspect that their thyroid cancer has de-differentiated. And so we're going to do PET to see if it's metabolically active. If it is, then we know they have thyroid cancer, but it no longer takes up iodine, so we can't treat them with I-131 anymore. Okay, pregnancy, it does cross the placenta. 8 weeks is when the thyroid is being formed, and so it will cause the fetal thyroid to be ablated, just like the maternal thyroid. All right, so back to hyperthyroid therapy, because we do 2 different types of thyroid therapy, right? We do hyperthyroid and cancer therapy. Hyperthyroid, what is our goal with hyperthyroid therapy? Is it to make them normal? No, we want to make them hypo. Our goal is to make them hypo. We want to make them so their thyroid is not functioning. And the reason is we used to try and make them normal. Like, okay, here's a little more iodine, then we'll check, a little more iodine, and we never succeeded at that. We always made them hypo anyways. And so it's like, well, let's just make them all hypo, and then we just give them one dose. We don't have all this radiation safety stuff and them coming back multiple times. We'll just make them hypo and give them a Synthroid pill. There's also anti-I-131 drugs. So anyone that cannot have I-131 therapy, so this could be children, and if I-131 is not available, there are medications that you can give. One is called methimazole, and the other one is called PTU, which is propylthiouracil. Both of these work to reduce hormone production. So this is an alternative to hyperthyroid therapy, an alternative to I-131. Okay, we'll skip all that. That's fine. All right, just want to draw your attention to this. If we treat a patient for hyperthyroidism versus thyroid cancer, we always think thyroid cancer is a lot worse in terms of radiation protection, but it's not. And the reason is, immediately after we give them the dose, their dose rate is going to be the same, hyper versus thyroid cancer. But 2 to 4 days later, the hyperthyroid patient is going to have a lot higher dose than the thyroid cancer patient. And that's because the thyroid cancer patient doesn't have a thyroid. This one has a thyroid and it's taken up all the thyroid. So this one's going to be radioactive longer. Okay. When we image them, so you said that you imaged the whole body for thyroid cancer, we can either use I-131 or I-123. Which one do you use?
For image,
Uh-huh.
we can do both, but I-123 is better.
Yes, yes, absolutely. So which one's I-123?
On the left,
Left, yes. Okay, and what's this artifact called?
star on the,
Okay, and what causes the star artifact?
it's the I-131 uptick and so high dosage, and they don't come out well on the picture.
Yeah, so high energy. And so what's happening is that those high energy gamma rays are going right through the septum of the collimator. So it's like streaking through the collimator and causing that septal defect. All right. Now, before we scan these patients, we have to get their TSH level up. And there's one of two ways of doing it. We can either take them off their thyroid hormone and let their TSH levels rise naturally. That's not fun because the patient experiences all these symptoms and it can take 6 to 8 weeks for that to happen. So they literally become almost non-functional because you can't function without thyroid hormone. You have absolutely no energy at all. So this is not a good option. The better option is to give them TSH. So if you give them TSH, then it gets all of their thyroid cells, gets them all ready to take up the I-131 or the I-123 when you give it. And this is intramuscular also. Okay. If you take them off their T4 and their TSH levels don't rise, that could be because they have some residual tissue that's producing T4. And if that happens, then you have to use thyrogen because there's just no way to get the TSH up. Okay, so before you do it, check their TSH level or give them the exogenous TSH, check for pregnancy, and no breastfeeding. And the reason we don't want breastfeeding is not because it crosses the breast milk, it does, but we don't want to irradiate the female breast. So this isn't one of those cases where they can pump and then dump. This is one of those cases they've got to stop breastfeeding for several weeks before you give this to them. All right, here's just some positive images of metastatic disease. This is a residual thyroid. Because after we do the I-131 therapy, we'll bring them back and we'll take an image because at this point, we don't know if it's spread. So we're going to give them the high dose of I-131. We'll see the residual thyroid, and then we'll look and see where it's spread. Here also, you've got lung activity. These are salivary glands, and that is the thyroid. And here's pulmonary mets. All right, which takes us to the parathyroid. So there's 4 parathyroid glands. They're located in the posterior aspect, 2 upper and 2 lower. This is what they look like on the thyroid. They're about the size of a pea, so they're really small. And physiologically, what parathyroid glands do is they produce parathyroid hormone. What is the job of parathyroid hormone? Parathyroid hormone is going to increase calcium. So when these patients come in, they're hypercalcemic. So they have really high calcium levels. And the reason they have high calcium levels is because they have a parathyroid that has gone rogue. And the parathyroid has decided it's not going to listen to the feedback loop because there's the feedback loop with parathyroids just like with thyroids. It's not going to listen to that feedback loop. It's just going to produce parathyroid hormone all day and all night. Now, how does parathyroid hormone increase calcium levels? It does it in 3 ways. First, it tells the bone to release calcium. And so you've got 2 types of bone cells, osteoclasts and osteoblasts. Which one breaks down the bone?
osteoclasts in the blood.
Osteoclast breaks it down. Osteoblasts build it up. So the parathyroid hormone increases the osteoclast and tells it break down the bone. The second thing it does is any calcium that you have in your body, your intestines are told absorb all the calcium. So that's going to increase your calcium level. And then the third thing, it prevents your kidneys from excreting calcium. So your kidneys hold on to the calcium, which also increases your risk of kidney stones. So usually when this happens, then you have another mechanism that causes the calcium to go back down. But if it just is constantly producing this parathyroid hormone, then you're going to have a high calcium level. So why is this bad? Excess parathyroid hormone increases calcium. It causes a lack of calcium in the bone because your bones are breaking themselves down, so that increases your risk of fracture. It also affects your nervous system and muscle contraction because these are ions that assist with those functions. And so if you have too much of this, it's going to interfere with that. And so you want to get a parathyroid level as well as a calcium level before imaging these patients. All right, let's skip that. Okay, so this whole thing right here is what I'm getting ready to show you here. So we're going to start here. We have high levels of calcium in the blood. When we have high levels of calcium in the blood, okay, that's caused by the parathyroid hormone, then the thyroid produces something called calcitonin. And calcitonin tells the osteoclast, shut it down. We don't want to break down any more bone. And when that happens, then the calcium level goes down. When the calcium level goes down, then the parathyroid says, oh, I don't have enough calcium. I need to make parathyroid hormone. So again, it's another negative feedback loop that occurs and creating hypercalcemia. All right, so why would we image these patients? These are all of our patients are going to come in with one thing, hypercalcemia. Many of them are asymptomatic. Sometimes they have recurring kidney stones, which makes sense because if their kidneys are holding on to calcium, that calcification is going to cause stones. They might have weakness and fatigue because the calcium plays a role in muscle contraction. And then they might have bone pain because the parathyroid hormone is causing the bone to break down. All right, so we have a primary hyperparathyroidism, and then we have secondary. Most of the cases are a primary hyperparathyroidism, which means we have one hyperfunctioning adenoma. And our job is not to diagnose hyperparathyroidism. Our job is to find the parathyroid that's hyperfunctioning. So our job with parathyroid imaging is just location, find it. Now, some of these are going to be ectopic. And so we can't just image around the thyroid, we have to go looking. All right, so primary hyperthyroidism, that's the most, they're going to remove the parathyroid. We need to image because we're going to help localize it. And sometimes we inject it and then they localize it through a gamma probe too. Just like with sentinel lymph node, they'll use a gamma probe in surgery. Secondary hyperparathyroidism, this is actually caused by chronic renal failure. So if the kidneys don't excrete phosphate ion, then that causes the low levels of calcium. Because phosphate ion and calcium, they're kind of inverse of each other, all right? So if you have too much phosphate ion, then it causes the level of calcium to go down. And what happens when calcium goes down, more parathyroid hormones going to be created. So secondary, all four parathyroids are going to be involved, and we'll call that hyperplasia. All right, in imaging wise, we can't tell the difference between primary and secondary other than if it's an adenoma, it's one. If it's hyperplasia, it involves more than one. Because hyperplasia, the problem is not the parathyroid. Because with primary disease, and this is for everything, with primary disease, the organ that is sick is causing its own problem. With secondary disease, the organ that is sick, it's because some other organ is causing the problem. So with primary, it's just one parathyroid because it's causing its own problem. Secondary hyperplasia, the parathyroids are actually doing what they're supposed to do. They're making parathyroid hormone. The problem is the kidneys. kidneys aren't getting rid of phosphorus, causing calcium to go low. Just like with thyroid. Primary disease, the thyroid is causing the problem. Secondary disease, what would be causing the disease with thyroids if another organ's causing it? Which organ would cause the problem? Which organ tells the thyroid to make hormone? The pituitary. Yeah. So pituitary adenoma can cause secondary disease in the thyroid. So again, if it's primary, that means the organ that is sick is causing its own problem. Secondary, organ that is sick is being caused by another organ. So primary adenoma is one. All right, there's two protocols that we can do. We can do the one that everybody does, which is the dual phase protocol, or the one that's only in textbooks, which is the dual tracer one. Actually, that's not true. I actually know a hospital that's doing dual tracer. So dual phase is the easiest one. Dual phase we'll talk about first. Here's dual phase. Dual phase just means we're imaging at two different time points. So we're going to image early and we're going to image late. We're going to use one radio tracer, and what we're going to use is sestimibie. Sestimibie, even though it's a cardiac agent, it's also a tumor agent, just like thallium. Sestimibie and thallium are both tumor agents. So we're going to take images early, and then we're going to take images late. And when we take images early, we're going to see the thyroid and the abnormal parathyroid. And when we take images late, we only see the abnormal parathyroid because it washes out of the thyroid. So it's very sensitive. We use sestimibie, 20 to 25 millicuries. It localizes in the mitochondria of the parathyroid tissue. Early phase, we're going to take early images about 15 minutes after the injection. And then, again, thyroid and abnormal parathyroid. Delay phase, this is 2 or 3 hours later. And sometimes we have to bring them back even later. And then many times we're going to pair this with CT. Do you guys have a SPECT CT? Just SPECT.
SPECT CT.
SPECT CT, okay. Yeah, so since we've added CT onto our specs, we're doing a lot more parathyroids than we used to. Because again, this is all about location, and CT is able to localize these. All right, so this is what this looks like. So if you get a question on your exam, what radiopharmaceutical was used to make this image? What would your answer be?
Sestimibie.
Sestimibie. Yeah, how do you know?
Because the heart highlighted.
Exactly, because the heart. And also, you know, because you have early images and delay images. And here you can see thyroid and abnormal parathyroid. Here is just the abnormal parathyroid. All right, skip that. Okay, so this is a negative one. So in this case, they imaged at 15 minutes. They saw the thyroid, 2 hours, 3 hours. Sometimes you just can't find it, or you have to go looking for it. So it could be ectopic. So at this point, you got to go looking somewhere else. Take a chest image. All right, here's another one. This one's just in black and white on top, color on the bottom, parathyroid adenoma there. This is an ectopic one. So here's the thyroid and 2 parathyroid adenomas located outside. And this one's pretty cool too, because these are early images. Look how quickly that shows up. And then later images, it washed out of the thyroid and you just see the parathyroids. Another ectopic one. So that whenever you see that, like a perfect circle, that is a marker. Even if it's not labeled, that's a marker. But right here, adjacent to that marker, and why would we put a marker there?
To see if they move.
Not to see if they move, but that's a good guess. To localize what that is. To localize what that is. So this is probably a chin marker, and this is a sternal notch. And so that's telling the surgeon that parathyroid is located below the sternal notch and to the right. So it's for localization. And then look at how beautiful that pinhole is. All right, we can also do SPECT images. So no coronal, axial, and sagittal slices. And then this was an interesting case that I found. So here is a patient that had a parathyroidectomy 8 years ago, and she has recurrent symptoms. So she came in, here's her 10-minute image. and here's her 2-hour image. So they can't find the parathyroid. Well, the patient tells the technologist that, oh, when I had my parathyroid removed, they took the other parathyroids and they put them in my arm. That's her arm. Yeah. So why would they do that?
Do they want to preserve that?
Yeah. Yeah, they want to preserve the parathyroid. And if they leave it in the neck, if it comes back, then she has to have another neck surgery. But if they put it in the arm and it comes back, now she can have a simple arm surgery. So, yeah. Good thing they injected on this side. All right. So the intraoperative localization, this is a gamma probe. So we can inject maybe 2 to 4 hours before surgery, and then they can go looking for it with the gamma probe. All right. That takes us to dual tracer technique. Dual tracer means we're going to use 2 different radio tracers. We're going to use something that goes to the thyroid only, and we're going to use something that goes to the thyroid and parathyroid. So what would go to the thyroid only? Well, what we scan the thyroid with, I-123 or technetium. What goes to both? Sestamibi and thallium, if you can get thallium, which we can't. So we take the sestamibi or the thallium, which goes to both. We subtract the tech or the I-123. So we're subtracting this out, and we're left with parathyroid. Now, if you do a dual tracer with sestamibi, you can also do delay imaging. So you can do dual tracer and dual phase. And the hospital that I was talking about that does dual tracer, that's what they do. So they do, I think what they do is they give the patient I-123, and then the patient comes back the next day. The patient lays with her neck supine, they image, then they inject the sestamibi. And so the sestamibi is going to go to the thyroid and parathyroid. They subtract the I-123 thyroid out, all of those counts and those pixels, and it's left with just parathyroid. So this is what it looks like. This is the sestamibi. This was actually sestamibi and I-123. Subtract it out, you can see that parathyroid.
How do they subtract it?
It's computer subtraction. And so it's a computer program that basically looks at, okay, what's the density of the counts from the I-123 in this pixel? And then I take the density of the counts from the MIBI in the same pixel, and I take those counts out. And I do that for all of them, even where the parathyroid is, but there's more counts here compared to where the thyroid is. And so when they subtract the thyroid counts out, you'll still see the parathyroid. Here's another one. There's the parathyroid. All right, here's that's, what are we looking? I don't know what we're looking at. All right, here's another, this one's just in black and white, and this one's in color. This one actually has a couple that you're seeing. So this is the dual tracer and dual phase. So the top is dual tracer. They used protecnetate and sestamibi, subtracted it out, and found the parathyroid adenoma. And then they went ahead and took delayed images as well, and were able to find the parathyroid adenoma. So you can do both. Here's another one where it visualized on the dual tracer, but didn't, I mean, I guess you can see it a little bit. This one's hyperplasia, so you see more than one. Hyperplasia is hard to see in dual phase because you don't have really great resolution. And so if you have more than one, it just appears like it's not washed out. So hyperplasia is actually better for subtraction. Okay, I have way too many of these. All right. Said I wasn't going to cover extra scan. Okay. All right, that is it for endocrine. That is a lot. But I think I covered the things that you're most likely going to see on the exam.